Now, in this video, we are going to discuss the myeloproliferative neoplasms, sometimes also called myeloproliferative disorders. Now, what are myeloproliferative neoplasms? These are a heterogeneous group of disorders characterized by cellular proliferation of one or more hematological cell lines in the peripheral blood. The patients are at increased risk of thrombotic or bleeding events. Transformation into a secondary acute leukemia is a possibility spontaneously or with the treatment of these patients. Now, what are different types of myeloproliferative neoplasms? One important is chronic myeloid leukemia, that is BCR-ABL1 positive. There is translocation of genes from chromosome 9 to 22 is called Philadelphia chromosome. There is a product BCR-ABL protein which causes uncontrolled proliferation of myeloid cells in the bone marrow, in the spleen, sometimes the peripheral blood as well. Then the second one is Polycythemia Vera. When there is a very abnormal production of red blood cells, there may be production of other cell lines like platelets may be increased or neutrophils may be increased. This is accompanied by, in most of the cases, JAK2 mutation, that is B617F type of mutation. Some of the patient may have the JAK exon 12 as well. Then the third one is the essential thrombocythemia, when there is abnormally high platelet production and megakaryocytes in the bone marrow. This is also accompanied with the JAK2 mutation as in Polycythemia Vera, but there may be other mutations like CAR or MPN mutation, they may be present. And then we got primary myelofibrosis. In primary myelofibrosis, there is abnormal proliferation of megakaryocytes and granulocytes. The bone marrow fibrosis is a feature of this disease. There may be splenomegaly, which is also present in Polycythemia Vera, and a massive splenomegaly in CML as well. And then this disease may also be accompanied by JAK2 mutation. There may be CAR and MPN mutations as well. And then there is an unclassifiable disorder in which features of many of these disorders are present. And then rarely we may have other like chronic neutrophilic or eosinophilic leukemias. So these are different type of myeloproliferative disorders. Now, what are the clinical features of these? The symptoms may be easy fatigability, anorexia, and weight loss. There may be abdominal discomfort, early satiety, left upper quadrant pain. There may be left shoulder pain. This may be due to secondary to splenomegaly. There may be splenic infarcts, or there may be perisplenitis, which causes pain. Most of this is seen in CML and primary myelofibrosis. Easy bruising, bleeding. There may be symptoms of thrombosis. Patient may have gouty arthritis. There may be priapism, tinnitus, or there may be stupor because of the sluggish circulation caused by leukostasis in the brain. Then on examination, you find pallor. In Polycythemia Vera, there may not be pallor. In fact, there may be plethora. There may be petechia and ecchymosis. There may be palpable spleen, or sometimes liver may also be enlarged. There is a syndrome of fever, painful maculopapular violaceous lesion on the trunk, arm and legs and face. This is called acute neutrophilic dermatosis or sweet syndrome. So sweet syndrome may present as fever and maculopapular rash. There may be pain. So this may be present in some of the patients. Now, how to investigate? Complete blood count with smear examination is very important. That gives diagnosis in many patients. Leukocyte alkaline phosphatase score is low in patients who've got myeloproliferative disorders. There may be high uric acid because of the turnover, or sometime when the patients are treated to reduce the cell count, uric acid production may increase. The red cell mass to differentiate spurious from true polycythemia. PCR or FISH technique used for BCR-ABL gene or the gene product, that is the protein called BCR-ABL1 protein. Test for JAK2 mutations, bone marrow aspiration and biopsy in some patients, particularly in primary myelofibrosis, to document there is fibrosis. Cytogenetic studies like Philadelphia chromosome, cellularity in most of these disorders. Marrow fibrosis and myelofibrosis, and in spent phase of CML and Polycythemia Vera. The management for chronic myeloid leukemias, imatinib mesylate. It's used in Philadelphia positive chromosome, CML in chronic phase, blast crisis, acute phase, or chronic phase after interferon failure. In addition to imatinib, other drugs used are interferon alpha with or without low dose cytosine arabinoside, hydroxyurea, dasatinib, or nilotinib. And then hematopoietic stem cell transplantation is done in some of the patients. Polycythemia Vera, therapeutic phlebotomy, hydroxyurea, radioactive phosphorus, and low dose of aspirin can be used to prevent thrombus formation. And in essential thrombocythemia, again, you can use aspirin to prevent thrombosis, hydroxyurea, and in some patients, anagrelide may also be used. Primary myelofibrosis, Observation in patients who are asymptomatic. Hydroxyurea, radiotherapy, splenectomy may be a choice when spleen is causing the pancytopenia. Ruxolitinib is a JAK2 and JAK1 inhibitor recently approved for the treatment of myelofibrosis, and then patients may ultimately require allogenic hematopoietic stem cell transplantation. So this is the plan of treatment for patients who got myeloproliferative disorders.